You are listening to Lifeboat for the Whitecoat podcast. Welcome to our second episode of Lifeboat for the Whitecoat podcast. Today, I would like to introduce to you Tanner Moore, the founder of Clearwater Health Direct Primary Care. Welcome, Tanner.
Thank you so much. I really appreciate y'all having me.
All right, should we jump in? Yeah, so I'm here with Heather Moore and Dr. Tanner Moore from North Carolina. So Heather and I are calling from Wisconsin. So we had a foot of snow a couple of days ago in our spring weather. So and it'll be melted in a couple of days. So
it's so different than we have here.
Probably not like that in North Carolina.
Oh, it's like beautiful and 67 degrees outside right now at 9 a.m.
Yeah. They say if you don't like the weather in Wisconsin in the morning, just wait till afternoon. So it's probably that way in a lot of places. But so glad to have you this morning and just appreciate your time. We know you're very busy. And I'm excited about this conversation because just the doctor's stories are so powerful. And we're talking about real life MDs, real life stories. And it's not just the anomaly or the exception. It's really, I think, almost becoming the norm of how many doctors feel. So excited to hear your story. So Dr. Moore, would you like to maybe give us an intro just about your background and how you ended up on this podcast?
Yeah, absolutely. I'll tell you a little bit about how I discovered direct primary care and then why we opened the type of direct primary care practice that we did. So honestly, like in my intern year of residency, I came from the Army. I just got out after 11 years in the Army, but I was doing an Army residency. And during my intern year, I was like, this is not sustainable. Like everything about this system, like people wish for a single payer system. And I came from like the largest single payer system and it's a nightmare. You know, it's rationed care, it's short appointments, it's people who are unmotivated and don't have an incentive to actually help you. And so I was looking for any opportunity to find some other way to work in medicine that would actually be fulfilling. And I didn't find that until my second year of residency when I went to the flight surgeons course. And at the flight surgeons course, it's pretty much all family doctors by and large. And everyone's just like, you know, shark eyes, just like kind of dead inside from the system and just drowning at all times. But there were a couple doctors there who were National Guardsmen and they were super happy, loved their work life, you know, just jolly all the time about it. And I was like, what on earth are you guys doing? I was standing kind of in a group of younger soldiers. And these guys were like, well, we're doing this new type of practice. It's called direct primary care. Here's how it works. Our patients pay a membership. There's no copay, no deductible. We can see them anytime we want. We do house calls. You know, we can get their labs, imaging, and prescriptions at like a 95% discount. And we have a much smaller panel, so we're able to actually deliver on what we want to, on the quality of practice that we had intended. And I was like, light bulb moment. I haven't thought of anything since. I went and got on the like podcasts on Apple, and there was like one podcast about DPCs back then, and he had like 30 episodes, and I listened to all of them in 2 days. And I was like, this is exactly what I'm doing. And I would kind of evangelize about that in my residency and in other groups of physicians. And many doctors would hear about this and say, especially civilian doctors, they would say like, hey, this sounds wonderful. Like that sounds perfect. You know, like spend more time with your patients, spend more time with your family, potentially even have a more lucrative practice, like be the doctor that you intended to be on your med school application essay, like that awesome family doc you described. But like, I don't want to take out a second mortgage when I already have student debt to try to open a practice. And I don't want to learn to hire and fire people. Like I've spent all this time becoming a physician, not an entrepreneur. And I think there's so much truth to that. And I was just in a unique situation because my pound of flesh for medical school came from a different part of my body, right? Like they took my time, not my money, to pay for my medical school. And I loved every minute of it. But I was in a different situation. So I knew, okay, well, I'm able to open a practice. I had promoted pretty rapidly through the Army and had become a brigade surgeon about 5 years ahead of schedule, which gave me the opportunity to learn a lot about leadership. Like not something I wanted to do, had begged to not get that job, but was kind of appointed to it and then deployed and had the opportunity to lead 7 physicians and 10 PAs overseas in multiple different countries with all kinds of missions going. And I was like, this is, when I transition out of the military, I need to find some way to apply the skills that I've learned here, which hasn't been clinic and running a clinic. It's really been like scaling care in a certain type of model. I need to find a way to superimpose that on the civilian sector. And when you're deployed, when you're in like a force comm unit, combat arms, it's direct primary care. Like we're asleep in the foxhole next to our guy. We'll take out their ingrown toenail, like right beside them. When we're on a jump, like on the drop zone, because we had paratroopers, it was all paratrooper division, the 82nd. Like if somebody knocks their shoulder out, they've got somebody hitting a knee with night vision goggles beside them and popping their shoulder back in and giving them ketamine within a couple minutes, and a couple of their buddies humping them back to the casualty collection point. So I was like, this is how I intend to practice medicine forever. There's no barrier to get to me. I'm able to do what I want. There's nobody restricting what I can do or saying like, well, you're not necessarily credentialed to get compensated for that at a level that you want. And I didn't want the dollar to rule how I was caring for people either, because like Charlie Munger said, you show me your incentives and I'll show you your outcomes, right? And that's kind of what's gotten us to this place. Like the incentives are for doctors to be they're perverse, and they incentivize doctors to like either overtreat or undertreat depending on the way where you are in the system, and then overcharge for things. Like the only training I ever got on billing and coding was how to upcharge for visits, and you're not supposed to say that, and that's not supposed to be acknowledged that that's exactly what this coding training is. But they're like, hey, you walked in the room and like, even though you didn't ask, have your eyes been blurry or have you had any pain? Like you noticed that they weren't red. So why don't you just document there, like, ophthalmological exam unremarkable, right? And so, and even like when we're opening a practice, and electronic medical records in the fee-for-service system will come to you and be like, we guarantee that your visits will be at least a 99214 every time. And I was like, none of this seems like practicing with integrity. And the most important person that I'm accountable to is myself, because I sleep with myself every night. I have to love me. And if I'm not doing what I feel like is right for the people I'm taking care of, I just won't be happy. And that doesn't speak for everyone. But so what we realized is all these other doctors also want to practice in this way, but they can't, like I said, take out a second mortgage and learn to hire and fire people and all these other things. So what if we open a direct primary care practice that enables other doctors to bridge from the fee-for-service system and into direct primary care without trying to become a DPC doctor and waking up 2 years later and realizing they're actually an entrepreneur, which that's what happens when you start a practice. You're like, dang, I thought I was going to practice medicine. Actually, what I'm doing is balancing books. So, yeah. And so what we do now is we provide the real estate, the staff, the electronic medical record, the panel, and the salary for doctors to walk out of the system and practice in the DPC model where they can be the doctor they were meant to be. And that's where that's kind of where we had started talking originally, Matt, was about this Lifeboat for the Whitecoat website that you guys are setting up, helping us to recruit doctors and let them know that DPC is even an option. Because like we're listed on other doctor recruiting websites. And what I'll say is like when I call somebody and I talk to them about direct primary care, many of them have never heard about it. So we kind of have a selection bias in the wrong way. We're talking to people who aren't already interested and have to be sold on it, which takes a year or two, like it did me, before they're ready to commit.
You are listening to Lifeboat for the Whitecoat podcast.
It's kind of amazing. I've heard a lot of stories, right? And I don't know if you know Dr. Paul Thomas. He was one of the maybe the rare ones up in Michigan that didn't go to the hospital system first. You kind of had your small version of it, but most doctors go into the hospital system, and it astounds me because they think that's their only path, right? And it really is voiced as their only path. It astounds me that perhaps among the most capable group of people in the nation, right? People that can get through med school and all the challenges and all the things with it, become a cog in the big money machine of a hospital system and don't know what to do. So if this is a group to try to handcuff or pick on, I don't think that's very wise. And I think once the word gets out about these things, doctors are far too smart and too capable to be just controlled the rest of their career.
I forget exactly how the saying goes, but it's like every system was perfectly designed to get the results it produces, something like that. So this is what's happening with physicians. They feel obligated to either go for residencies and specialties that are much more highly compensated than primary care because the system has burdened them with a massive student debt. And let's be real, a lot of physicians haven't earned a dollar in their life yet. They've been career students and they're like, where does money come from, right? Like I come and be a good student. How does one get paid? Yeah. And so they don't really they look at all this debt and they don't have any idea of how they're going to get rid of it. There's no financial education for physicians either. And if I was designing a perfect system where I could have super valuable people that have a really good skill be dependent on me for employment, they've set up a pretty good one. And even if they're miserable in employment, they're too afraid to leave because they've been taught how to manipulate systems to like slowly progress the corporate ladder or the hospital ladder. And that's what you get with a lot of physicians is people who are afraid of the amount of debt they've taken on. And the hospitals come in, they're smart too, like they wave a big check for year one in front of the doctor's face. They say like, look, we'll pay you, maybe $300,000 your first year and we'll help you move all these things. And it's like, heck yeah, you're getting that doctor stuck. Their kids are going to be in the school system now, right? And now you've paid them $300,000 a year. And hey, next year it's all RVU based. But then when they get onto their RVU basis, it's like, whoa, I'm only going to make like $150,000 this year. I have a $300,000 lifestyle right now. My kids are in private school or whatever, because doctors also feel like they sold their 20s or sacrificed their 20s in exchange to thrive in their 30s and 40s. So they get out, they're like, a person who's thriving must have a Mercedes and a big house and go on vacation.
Country club membership.
Yeah, exactly.
Yes,
They get themselves caught in these just financial problems and then they can't escape. That's why I call it the golden handcuffs. And now
yeah.
they were seeing 20 patients a day, making 300. Well, turns out they only made 100 enough RVUs for 150K a year. So they need to double that. You need to see like 36 or 40. Yeah. And so that's kind of what we're trying to help. Like, I think if DPC gets the word out, we can fix that because honestly, DPC can offer a better financial package than the hospital can because primary care is not solvent in the fee-for-service model. Like that's why the village clinics and Walmart and stuff went out of business because they didn't have a big system to refer into. And primary care is really just the whale's mouth meant to swallow up all the krill and then digest them down below in this big referral system. And in DPC, it's the opposite. Like, hey, people pay us a monthly to keep them healthy. We try to manage everything in-house. If we need to do a virtual referral, we'll do it that day and try to keep it all there. It's like we do vasectomies, we put in IUDs, we drain abscesses. I'm cutting off a bunch of skin lesions today. Like all of that stuff should be captured, but we're not compensated for that. We're compensated to be a good doctor, and our financials work out better to where if DPC is very solvent. So like us, for example, we start our doctors at $240,000 to see 6 or less patients a day. And then we'll pay them 400,000 if they want to see 10 patients a day. Right. And like what we're trying to do is restructure the incentives so that people don't feel like they have to go into a specialty in order to get the compensation they need for the lifestyle they want.
Could you talk about patient panel and the differences? Because you just mentioned, I think the two parts, but I've had doctors ask me, right, if I only see 6 to 10 patients a day, does that even pay the bills? So, somehow this has been ingrained that I need to have these huge patient panels,
Absolutely.
30
Something
patients.
that, like I was just talking with a new nurse practitioner that we brought on and was explaining to her like, hey, some days we'll have a day of clinic where like there's 2 or 3 people that come into this like big, beautiful clinic that we have. And that actually means you're doing a good job, not a bad job. Because like the better care you take with people, like honestly, the less services they're going to need. So we look for opportunities to upserve them all the time by like calling in and be like, hey, we have this other service you haven't done before. Let's see if you like it type thing. But the thing to keep in mind is in DPC, every single one of your patients pays you every single day. Like we're $99 a month. It's $3 a day. Essentially, we get paid from every single patient, whether we do something with them or not. Like the day they need to come in and we're having this come to Jesus talk about their alcoholism and type 2 diabetes and stuff doesn't pay any more or any less than any other day of the year. Right. And so what I try to help people understand is that one, every family doctor needs to see about 1% of their panel per day. That's an old AAFP metric. So in primary care, if it takes 3,500 patients in fee for service to pay the bills, you need to see 35 patients a day. Well, honestly, it only takes about 250, 300 patients to pay the bills in DPC. The bills aren't high. There's no administrators, like everyone in our practice is somebody that sees patients. The phone rings, it goes to all of our phones and just whoever's available answers it. We don't have, it like in fee for service, there's 3 administrators per actual like clinical body. So we don't have that overhead. So if you get to where, you've got 600 patients, you only need to see, according to the AFP, 6 per day to keep them all pretty well balanced. Now, DPC is high touch. So like we'll reach out to people in multiple ways in multiple days to just make sure they're on the path that we want, because we're invested in their health. Like I said, the better care we take of them, the less they need us. So you show us, like the whole incentives and outcomes thing, like, hey, my incentive is for them to be as healthy as possible. If they're not, they're going to call me on Saturday. So I want to take very good care of them.
When it came to starting your practice, when you were analyzing how to get started, how did you find the resources and the partners that you needed in order to get some of that initial business set up and location, all of that? Was it a lot of DIY, or did you have some good
everybody's
partners?
making up everything and everyone is winging it. Like if you ever look at someone successful and think they had it all figured out, like, no, they slowly might have figured it out. And that's kind of, I appreciated that a long time ago. And even if you go, like I go lobby in DC twice a year and like they're winging it too. And so what I did was I was on deployment and I just ordered, because Amazon Prime still delivers even like no matter where you are in the world. I ordered every DPC book I could find on Amazon and I read them and highlighted them. I contacted the authors. I was reaching out to Shane Purcell and Doug Frago and all these guys, and read Paul Thomas's books, highlighted everything, made like a to-do list, and made sure I got a good understanding. I listened to Mariel Conception every single episode that she would put out. I was like the first person to listen to it, and Bluetooth earphones are the secret. So I'd lay in bed with my Bluetooth eye mask and be listening to this stuff. And then using the Direct Primary Care Alliance they have something called the DPC Quad, which is like DPC University type thing. So I got on there, I read every single thing that it had to say. I went to a DPC Masterminds put on by Dr. Shane Purcell and learned a ton there. And then just was not afraid. Like we all end up in the same place. I was like, even if I might as well swing for the bleachers. I only get to swing so many times in my life. And like, this is a beach ball. I'm going to try to knock it out of the park. So yeah. And then reaching out and, like you put up, you can make a DPC pro forma. You can have one that looks like you have a very slow, poorly growing practice and the numbers are still very good compared to your overhead. So like I was intending to start in about August. So we were building a practice out in Apex, North Carolina, which is like it's got some statistic like best small town to raise a family, and America's like most rapidly growing boom town. It's 53 or like 47 to 53 minutes, depending on traffic, from my farm. But I was like, that's the place to do it. Like we need to go to the right environment. I'm a hunter. So like the saying is, go where the deer are, not where you think they should be. So like that was pretty much how I approached this. But before we opened, we put up our website, and I had people calling. Like we launched the website in December 15th. I had people calling, wanted to join the practice pretty much immediately. Not a lot of them. I don't want to like create this like false idea that if you build it, they will come. But like people were wanting it. So I was like, okay, well, I don't have a place to work right now. I can't say I can do virtual, but virtual is a farce. I just want like to make that completely clear. Like your doctor needs to like look, listen, and feel you. So I got a wrap on my car and started doing all house calls. And like I would, if somebody needed something that I could take care of over the phone, they could text or call me. It was like my personal phone number that they were reaching out to. And then I would go do a house call for every intake appointment and every sick need, And then we got a large employer reached out to us wanting care. They were an hour and a half from my house. And they were like, hey, we have this many people. Would you be interested? And I was like, yes. It was in the opposite direction from where we were building an office. That's where we are right now, as a matter of fact. But I was just like, any opportunity that comes, I'm just going to try to swallow it up. I don't care. Like, if it kills me, this will happen. And so now it's been successful having the large employer, and our other office in Apex is growing mostly from just the regular Gen Pop community, because people, have word of mouth is a force of nature in DPC, that's for sure. So like people want to aim for employers, and I'm one of those people because I want to fill panels, but word of mouth will also grow you nice and a steady organic growth.
You are listening to Lifeboat for the Whitecoat podcast. I do have to say that, the term DPC, and I'm just going to talk about the general population for a moment. They don't know that term, right? Once Heather and Matt, and I mean, I've known Heather for a long time, but once they started talking the verbiage, I'm like, you have to slow it down for me and help me truly understand what you mean, what this is, and how this works. Now, ironically, yesterday, as I was having my morning coffee, I was watching Good Morning America, and they did a whole story on this, and they call it concierge medicine. And they put a negative spin on it. Like, boy, you better watch out for this. This is what's happening. The trend is happening in the United States. So what do you feel about that?
I feel like large money probably sponsors a lot of things you see on the news.
Absolutely.
And concierge is a bad word. Like I was talking about integrity earlier. I know concierge doctors. I evaluated concierge practice before deciding what I wanted to do. And concierge is just double dipping. Like all you're doing is charging people for access to you without doing any magic tricks, as Shane Purcell would say, right? Like you can't go out and negotiate special lab prices or imaging prices or do any of the other things. They still have a copay, a deductible. They better have the best insurance. Like they better get the platinum plan off the marketplace, because a DPC practice is swank, or a concierge practice is swank, and they want to be billing a 99215 at maximum compensation for everything. So it's just
Well,
like opposite direction.
Ironically, they were not saying anything about that. It was a membership structure. That's how they deemed the concierge medicine trend. It was a membership-based structure. And they interviewed a woman in Michigan whose doctor was leaving the hospital system to go into her own concierge medicine practice. And this woman could not afford her membership fee because they spun it as incredibly negative, and she would have to pay thousands of dollars to continue to work with her and things like that. So I'm not sure. I think they're trying to spin a term that truly isn't real in today's world.
And when I first found out about DPC, I was like, these people are going to get killed by Blue Cross Blue Shield. Like they'll find out this is happening and step on it like a bug. And that might be what's happening there. But there's like, anywhere there's smoke, there's at least a little bit of fire. And like, yeah, I know doctors who go out and they charge like a very high fee. And the thing is, this is the free market economy. Like if they want to charge 4 times as much and see 1/4 as many people, then they're going to make the same amount of money and do 1/4 of the work. Then that's kind of on them. And if that's the doctor that you want, you need to either like prioritize it enough to where you can afford it, or find a different doctor that's more in alignment with your values. And like that's what we're trying to do, is return this to the free market system rather than the like truly monopoly that it is right now. Because even if people were like, and like she's saying, I don't have enough money to pay for this. We had a patient quit one time because she said she didn't have enough money to pay for DPC, and we're $99 a month. And we do advising to people to help them figure out their healthcare spend, because like we try to first do no harm physically and financially. And we know more about the healthcare system than any of our patients because we live in it all day, every day, and they like interact with it sometimes, and it's scary and confusing. So we do an assessment on what people's plan is. Here's your primary care plan. This is going to be 95% of your need. What are you going to do if, God forbid, you actually do get in a car wreck and have to be in the hospital for 3 months and it's going to cost $500,000? Well, so she said she couldn't afford DPC because she was spending $1,500 a month on Blue Cross Blue Shield premiums. And so she saw us frequently. She saw us like once or twice a month, and that's more than a lot of patients do. And she had treatment plans in the process, but somehow the messaging from the BUCA plans, like the big insurance companies, has been so effective and so pervasive that she thought the thing she couldn't live without was this super expensive plan. 1 month of her Blue Cross Blue Shield costs more than an entire year of her DPC doctor. And yet she was like, I can't live without that. She still had a $2,000 deductible too. It's like over the course of 10 years, she's going to pay, what is that? It's like $180,000 over the course of 10 years. And during that time, she'll probably only have about, probably less than $10,000 of unforeseen medical expenses, which she'll then get to pay her $2,000 deductible. So they'll only pay $8,000. So she paid $182,000 in exchange for having a few $1,000s covered. It's just a really, really bad idea that somehow they've gotten people to buy into.
Yeah, the financial part, I think, and Dr. Keith Smith, Dr. Keith Smith, are you going to FMA this year? Yeah. He said, right, that we need to take care of the patient physically and financially, right? To bankrupt them financially is doing harm. So this thing about do no harm, as you mentioned, should apply to the financials. Now, most doctors in the hospital systems, as you mentioned, they're not told about this. In fact, when you ask them, they're like, that's not my area, right? That's kind of
And I don't think it's intentional what they're doing. They just don't have the information to make a good decision.
They're not allowed. And it's better to keep the smart people out of it too, right? And you just do the care. That's your job, and you stay in your lane, and da-da-da. Yeah.
Right. I moonlight in an ER, and I had a guy come in the ER, construction worker, uninsured, paid his $250 charge at the front desk. I don't know if they call it a copay or what, because it's not his full copay, just like to register, you have to pay $250. And then he gets brought back to the room, which that's a facility fee of another about $1,300. And then the physician's fee is like $900 before you've even been seen or done anything else. And he was like, how much will this cost me? Before you do anything, like he needed stitches, how much will this cost me? Nobody could tell him, like no one in the whole hospital could figure out what stitches were going to cost him. And I'm me at all times. So even though I'm working in this ER, I'm like, hey man, you're going to get 30 cents worth of stitches and like 10 cents worth of saline and $2 of lidocaine. And God only knows what it's going to cost. I have no idea. Finally, they came back like 45 minutes later and they were like, it's going to be between $450 and like $1,400, depending on like what type of insurance he has or these other variables that were out of his control because he didn't have any. And I was like, bro, here's my card. You have like a good 12 hours left before this gets closed up. Like if you want to leave, this will be essentially free with a membership. So it's going to cost him $99 to get this taken care of. I can tell you right now. And so that's what he did. He was like, all right, I'm out of here. And we went out there. I was doing house calls, had all the stuff in my car. Like I was like, I get off my shift in 2 hours, just in the parking lot, sewed up his finger. And I was like, see you tomorrow. I followed up with him the next day to make sure everything was still healing well. Right. Whereas like usually in the ER, I'll put in like needs follow-up. I just averted a cardiac, a CHF exacerbation, a congestive heart failure exacerbation. Like this guy has to be seen within 2 days. Right. And we'll call their primary care clinic. They're like, soon as we can get him in, it's 2 months. And I'm like, dude, well, we might as well admit him. And that's where a lot of admissions come from. They're like, inadequate follow-up is an admission criteria. And that's what a lot of them are.
Wow. My story recently, I'm a mom of 2 teenagers, 1 teenage boy, and he stepped on a rusty nail. So he was convinced that he needed to go to see the doctor immediately. And I have the large insurance fancy plan. And so I took him to the urgent care, and I think 2 months later, I was sent a bill for $700. And I remember the doctor that was seeing my son, he's like, there's nothing I can do. There's no puncture wound. You're going to be fine. But here's some rubbing alcohol ointment that you could rub on your foot tonight. And he kind of shrugged his shoulders, and I went, oh, I know that look. But yeah, I mean, it's just wild.
The doctor has no idea what he was charged. Like he doesn't even have the ability to find out what he was charged.
You are listening to Lifeboat for the Whitecoat podcast.
We're taking care of one of our employees here, a clinical pharmacist who went and had a surgery done. And then his insurance, like paid a certain amount, but he still owes this egregious amount. And he's like, hey, like this is outlandish. I want to see my itemized bill. So they sent us the itemized bill and we reviewed it for him. It is straight up fraud. Like we look for waste, fraud, and abuse. They're sending money back and forth over and over with no description of why. They're like $68,000 this way, $67,994 this way, $27,000. And it's just like, debit, credit, debit, credit, debit, credit for like 15 lines. And it's like, wow, a money laundering scheme. I get it. Like you get to charge a fee for financial services or something. Explain to me why this happened. But like, who do you talk to at Blue Cross Blue Shield to get that answer? Like how many years can you spend in phone trees to find that out?
Wow,
And what
that
they're
is
actually
amazing.
a self-funded plan. Just Blue Cross Blue Shield is adjudicating and they're using their network. So somebody is like, sees that big reservoir of money and they're like, how many fees can we charge on this money?
What I found is that the more you learn about this game, the more you learn about the healthcare industrial complex, as sometimes I call it, and many call it, right? Just the more you find and the more concerned you get. And I would like to ask you one question to make sure we have time for. Much of the audience here, I think, as we talked about, there are many physicians inside hospital systems or inside this industrial complex that are very frustrated, that have studied a long time, spent a lot of money in that education and residency and so forth. And here they are, they've got the golden handcuffs on. What would you tell those physicians where they are today?
To get out of the system, like how they could do it.
Yeah, is there a way out, or what should they first do? And that's maybe what Lifeboat for the Whitecoat is about finding physicians or starting in practice, right? So we're trying to be an aid there. But just what would your message be to that group if they're feeling hopeless and they're feeling like, wow, I've got like 30 years left of this and I'm kind of miserable and this is not at all why I went to med school?
Yeah, and what they're feeling is regret. They feel like they invested everything in this like false narrative and there was no pot of gold at the end of the rainbow. And I go around and lecture medical schools and residencies all the time. And the first thing I try to tell all of them is like, hey, you made a great decision. You did exactly what you needed to do to be positioned perfectly to be the person you had envisioned that you would one day be. You're in, and like this problem isn't you. You're in a system that just wasn't made for you to thrive. Then like nobody, like fish can breathe underwater and nobody criticizes them because they can't climb a tree, right? Like they were made to do something and do it great. It's just that if you take that fish and put it out of water, they seem like they're terrible. And that's what doctors are. They're in a place where they're handcuffed. They can't actually affect change on their patients. They feel like they are tied to the system because it does require a system to run. For a doctor requires a system is a better way to say that. Like doctors, like people in the army, they would be like, send Dr. Moore out to be on the drop zone because we have this like high risk jump going. And I'm like a train conductor. Like I can pull a ton of freight, but I need a train, right? Like there's a system that like lives around me. You're better off to send like an EMT a lot of times, right? So they just need to know that like other people have figured out how to build this train around you so you can be a great train conductor and move freight in the private sector. And that's the place where you can actually affect change. You don't have to go to like your nurse case manager or your care coordinator and be like, hey, is there anyone who could take this referral? Like Google, man, like look up some other specialists in the area and call their cell phone and see if they can fit your patient in today. Like all of the things that we use that make our regular life super simple are available outside of this like Byzantine, malignant, bureaucratic mess that has become the medical industrial complex. And other people are ready out there with practices that will hire them. Those practices list themselves on websites like Lifeboat for the Whitecoat. And that's a great place to start looking. And if you're interested in opening your own practice, then do like I did and just like kind of buck up, be ready to work super hard like in residency. But you'll be maybe more satisfied if you always wanted to be your own boss or have your own vision of something because you won't be working in somebody else's vision.
I mean, that was the other mission-driven aspect that we were trying to fill is helping doctors feel supported and ready to open their own practice, realizing that they don't have the business training oftentimes that's sometimes needed So we've created a consortium of specialists in banking, accounting, legal, and all the things to help people feel safe and secure within their practice to start from, solid ground so that they can make that move and shift quickly, having the right partner.
That's absolutely key, because it gives you just like that safety net, especially a line of credit. I think the best thing that the GPC practice can have is definitely a line of credit, because it's unforeseen what your growth is going to be like. It might be stagnant. There have been months where nobody joined the practice, and that's scary. There have been months where we're overrun. That can be equally scary. You need money to deal with both of those problems.
Yeah.
Well, we are at the end of our time. I thank you so much, Tanner, for joining us today. You did mention Lifeboat for the Whitecoat, which is our podcast. The website was launched a week ago, and it is whitecoatlifeboat.com. It is available positions in independent practices around the United States. It is growing, so make sure that you join. There is a 30-day free to start off with your first position if you are an employer. And if you are looking for a job and you have your independent practice hat on and you want to get out of the hospital systems, make sure you go to whitecoatlifeboat.com. Any last minute advice to sign off?
Don't be afraid. We all get to swing once. Swing as hard as you can. Like, that's it.
I love that. Thank you very much. This is our second episode of Whitecoat for the Whitecoat podcast.
This episode of
Until next for the Whitecoat podcast. Please make sure you visit whitecoatlifeboat.com.